Dipping your toe in the FASD water is not something to be undertaken lightly, because making a diagnosis is technically challenging. It involves a lot of collaboration between different disciplines. For the psychologists in the room, you can go off full of self-satisfied smugness because you're the major contributors to the diagnosis, as we'll see when we get into the brain domains. And so, does anybody here feel just really absolutely comfortable and relaxed about asking people about alcohol? You know, you're just so chilled you don't even notice it. Can anybody hear? No? Yeah, so there's not really anybody in that group. And because this may have major implications for the individual, the mother, the parents and the family, that's appropriate. But asking about alcohol, which Liz has already been through, it's like everything, it just gets better with practice. And so the first few times you do it, if you're not already doing it, may seem a little bit difficult, a little bit stilted, but my suggestion is just build it into your normal practice of history taking. You know, you don't want to do a big sigh and then go, oh, now we need to ask you the alcohol question. Okay, just build it in as part of any history taking you would do around pregnancy-based exposures. Okay, so the Australian Guide should be our Bible in terms of making FASD diagnoses. And I think any of you who've looked at it will see that it really walks the clinician through everything that's required to make the diagnosis, both in terms of knowledge but also in terms of process. The full medical and developmental assessment is really based in the history, and unless we ask questions about alcohol, there's a fair chance that a child with FASD may skate through the whole system with this question never being raised. And they may be given other diagnoses that are either partially appropriate or they may be misdiagnoses, and there's plenty of articles in the literature about that. But taking that history and doing that medical examination needs to be combined with a thorough neurodevelopmental and psychometric assessment covering off on the 10 brain domains. And for the paediatricians in the room, it's really a standard morphological examination, plus particular attention to growth, including head circumference, and consideration of whether you should do a chromosomal array and exclude fragile X, plus anything else that you think is appropriate. And we try to do that 100% of the time, but as you know, there's often a slip somewhere between giving someone a pathology form and them actually having the blood taken. So we're looking at using buccal swabs, which could be done then and there on the spot to try and improve that. Okay, so this is just a section out of the guide, and really the 10 brain domains are outlined there, and the two options for FASD with 3 sentinel facial features or with less than 3 sentinel facial features. And remember, to get a diagnosis we need to have severe impairment, i.e. less than 2 standard deviations below the mean, less than the 2nd percentile function in at least 3 of those neurodevelopmental domains. And we're going to spend time after this session really drilling in some detail into those domains, because I think even if you're not a psychologist, you're a non-psychologist, the non-psychologists in the room, myself included, need to have some understanding of how our psychology colleagues are arriving at this diagnosis. You don't need to become a psychologist, but you do need to understand at least some of the processes. So sentinel facial features, you all should know by now: short palpable fissures, smooth philtrum, thin upper lip. So the history, and again, I'm going to keep looping back to this, the starting point for your consideration that the child in front of you may have FASD is really asking about alcohol. And as soon as you get a positive alcohol history, I would expect you all to mentally move that child into a high-risk category. They're immediately at much higher risk of negative neurodevelopmental outcomes. And if there's one thing that we've worked out from our clinic is that when I see them as a paediatrician and I think, well, yeah, they've probably got, moderate impairment, is that I'm not a good judge of their level of impairment. Once they've had those 10 domains assessed, almost invariably they are much more impaired than I first thought on a 1-hour assessment. Okay, so I think kids and families become quite adept at concealing their levels of impairment, and sometimes with teenagers it's very important to try and drill past that cloak of competence and get past those initial scripts that they've learnt to run in order to appear to be competent and functional. In terms of neurodevelopmental assessment, by the end of today you should be able to recite these 10 domains in your sleep. So brain structure and neurology, which really tends to be one of the things the paediatrician looks at, motor skills, cognition, and all the others are our allied health colleagues. As a paediatrician, I'm interested in, has the child got microcephaly or not? Okay. Do they happen to have had incidental evidence of structural brain abnormalities, i.e. did they have a head injury and happen to have a CT or an MRI because someone was worried about a subdural and that was normal, but it happened to show that they had partial hypoplasia of the corpus callosum or any of those other abnormalities there. So I usually ask, has your child ever had a serious head injury? And most people will say, well, he bumped his head the other day, but did he lose consciousness? Did he have to go to hospital? Did he have imaging? Seizure disorders is another important thing. Obviously we can exclude febrile seizures, and any other neurological diagnoses that including the ones listed there, are also important to specifically ask about. Anything else should be just picked up in your routine history taking. Physical examination, most paediatricians will do growth and plot it on the relevant paper or electronic growth charts. If you have the luxury of serial measurements, that's also important so you can see what the trend is and whether there's any point in the past where perhaps the child's growth was significantly impaired, and then obviously read the circumstances around that. In a child with microcephaly and all 3 sentinel facial features, you can make a diagnosis of FASD just based on those 2 factors, even if prenatal alcohol exposure is not known, because we know that the presence of the 3 facial features have a greater than 95% specificity for prenatal alcohol exposure. Now, in this circumstance, obviously, if you identified that child at a young age, you'd be very careful to follow them up developmentally and make sure that they were provided with more standardised assessments down the track when they were older. Just a little extra point there, that microcephaly is the most frequent cause of microcephaly in our Indigenous population was prenatal alcohol exposure. Okay, in terms of the facial features, so measuring eyes is sometimes difficult depending on the cooperation of the child. But you're measuring from point A, which is known as the endocanthion, to point B, which is known as the exocanthion, and it's really just where your eyelids meet. Now, if someone's got what are called epicanthic folds, which this child does have, those little curved bits running down the medial aspect of the eye, like these things here. Sometimes it obscures the endocanthion, the medial part where the eyelids meet, and it can be a little bit difficult to get an accurate measurement. And bearing in mind, ideally, the measurements can make a difference if they're only, 0.2, 0.3 of a millimetre different, might make the difference between whether they're less than 2 standard deviations below the mean or not, because that's the cutoff. We're looking at the smooth philtrum. So for those of you who are unsure about philtrum, it's that little dent on the top of your lip. And so if you just have a little feel there, and if you haven't got one, don't worry, because the philtrum smoothness does vary a little bit, even in the absence of alcohol. So we're looking for a smooth philtrum and a thin upper lip, and you can see this little person here, the upper lip is missing that nice Cupid's bow appearance that we've come to associate with upper lips, and it's actually quite thin. So why, as paediatricians, do we get so hung up about the face? So the first trimester is really a window into fetal brain development. And as I said before, having 3 facial features has a greater than 95% sensitivity and specificity, and it doesn't vary by gender, age or race. So they remain consistent over time. And so if we as paediatricians do identify someone with 3 facial features, it's highly predictive that that child is also likely to have abnormal brain structure and function. Now, having said that, the slides Liz put up earlier demonstrated about 22% in that cohort had 3 facial features. I guess in our clinic that was probably the number to start off with, but over time, perhaps as we've seen children with at the more severe end of the spectrum, we're probably down at around 10%, or maybe even less, would have all 3 facial features. So as I said, the brain guides facial development on a structure, cellular and molecular level, and as I also mentioned, cells from similar sheets of tissue develop into the brain and face. Now next we've got a little scanned picture of I'm pretty sure it's a mouse embryo. So I want you to pick which one is the normal little mouse face and which one is probably the one that was exposed to alcohol prenatally. Let's think about the facial features, and head circumference maybe is the other clue. Okay, so which one do you think is the one on the right exposed or non-exposed? Non-exposed, yeah. He's got a nice little philtrum, some pretty well-developed little mousy lips, and a nice big head, whereas the one on the left, the philtrum's been obliterated, as has the lip, is quite indistinct, and you can see that this is a suggestion that perhaps this little mouse embryo is microcephalic. So, as goes alcohol, goes the brain, goes the face, and goes growth, and that's why we're worried about sentinel facial features. Okay, so as well as identifying prenatal alcohol exposure, as I said before, I would expect you to mentally shift that child into a high-risk category. Also, with 3 sentinel facial features, they should shift into that high-risk category as well, and to ensure that they have excellent developmental surveillance, or if there is obvious developmental or behavioural concerns, that it triggers a comprehensive neurodevelopmental assessment. Okay, so, and this is another way of thinking about it, that if you identify facial features, microcephaly or growth problems, is that a biomarker for prenatal alcohol exposure? So many paediatricians, child health nurses would see children because of growth concerns, failure to thrive, slow growth. So more often than not, this is perhaps related to things other than prenatal alcohol exposure, but if you don't ask, you will never know. So for those children, that's another trigger for ensuring that we ask carefully about alcohol. And I actually think that in any general paediatric clinic, any child development clinic, any child health nursing clinic, any midwifery group practice, obstetrician, we should be routinely asking about alcohol. And even more specialised than that, perhaps paediatric neurology and certainly cleft craniofacial clinics routinely ask about alcohol, because we know that alcohol exposure is associated with midline defects, and we've had several children that have had cleft lips or palates, obviously repaired in infancy, that have come to us for assessment of FASD. There are basically two ways that you can do it depending on your circumstance. One, direct measurement, which we'll run through in a minute, usually with a clear plastic ruler to measure the PFLs. Or the other way we can do it is to take a digital photo and use facial analysis software, which is from Susan Astley at the University of Washington, to then analyse the photo. There are pros and cons of each. The photo analysis software is not particularly expensive. I think it's less than $200, and once you get it, you're allowed to copy it onto other computers. It's thought to be more accurate because trying to measure a child's PFLs when they're leaping around your room and you're trying to avoid too much parallax from the ruler can be problematic. But if you don't have access to the software, then that method is more than acceptable. So the tools of the trade are really a tape measure, clear plastic ruler, and the lip philtrum guides, which you can see one set there for Caucasian children, and there's another set for African American children, which are applicable to our Indigenous population, and they're just a free download from the University of Washington. Get your small plastic ruler, take off your glasses and definitely their glasses, and get down at their eye level. Now, when doing this, in particular, and the same applies to taking photos, so you take the photo at the same level as you would measure, and the tendency is that we all tend to take photos of children looking down on their face, okay? So it's really, instead of taking a photo here of Sue, I would need to actually get down here, so I'm actually at eye level. Okay, is everybody with me? And I'd probably ask Sue just to tilt her chin down a little bit. So get at their eye or ear level, there's a diagram, and then ask them to look up. Now this is the complicated bit, because what do kids do when you ask them to look up? They go like that. So you need to ask them to look up but hold their face still. So a complicated question for little kids. So ideally what I usually say is, can you hold your face still and just look at the top of my head? And they just tilt their eyes up a little bit. And so you get that view which we're about to see here, there. Okay, so someone looking up, and in this instance you can see this person doesn't have epicanthic folds, so you can see their endocanthion, which is the medial margin of their PFLs quite well, and you can measure that, and then you can use what's essentially a spreadsheet, which is again, is that a download, Liz, from UWA? Yeah. And you just put in the child's birth date, the date you measured it, it calculates the age, and then you put in the PFL distance, and it tells you whereabouts they sit in the normal population. So you're concerned if their PFLs are more than 2 standard deviations, i.e. a Z score of greater than -2. You can assess the philtrum and the lip just using the naked eye, but ideally holding the guide up, the lip philtrum guide up beside the child's face. Now, as far as we go here, 1, 2 and 3 aren't within normal limits. It's only 4 and 5 that you would classify as being indicative of FASD. As you can see, there's an obvious gradation as we go up from number 1, where we have a very distinct philtrum, and the philtrum's really got 3 parts. It's got a central valley and 2 lateral columns, which you can see really clearly on number 1 down the bottom. And then as we go up, it slowly becomes more indistinct. So you can still see that central valley and the 2 lateral columns in number 3, but by the time we get to 4, it's starting to fade out. The columns don't reach right to the bottom of the nose. And number 5, the philtrum's almost completely obliterated. And the philtrum is a distinct subcutaneous structure that doesn't develop in the presence of alcohol. And there's also the 3/4 view there. Now, when taking photos, I find the 3/4 view is the most helpful for looking at the philtrum. And these scales have been frontal view, 3/4 view, designed so that you can pick the difference just with the naked eye. And as I mentioned, the top 2 are considered facial features of FASD, and the bottom 3 are essentially regarded as being within normal limits. Okay, and there are no differences between African American and Caucasian charts, that should say, except for lip volume. Okay, philtrums are the same depth. And this, again, is what I tried to demonstrate with Sue. And so you need to get down a little bit lower than feels normal. And that green line, known as the Frankfurt line, goes through your ear canal and the bottom of the orbit. That's the line if you want to get anatomical about it. And the other thing is, don't let children smile for the camera, because as soon as they see a camera come out, they want to smile. You don't want them smiling, because this is what happens. That's the same child. The top photo is where the child just has a neutral expression on their face, and the bottom one, they're smiling. And look what happens, their top lip disappears with the smile. So you might be tempted, based on that photo, to say that child has a lip 5, when in actual fact they look as though they've got about a lip 3. In terms of physical examination, there's been a lot made about dysmorphology of FASD, and originally it was a dysmorphologist that coined the diagnosis, or at least one of the original authors was a dysmorphologist. And so there are many subtle features, dysmorphic features that can be picked up in a careful physical examination. Now, in the absence of facial features, even if the child had every single one of these, does that equate at the same level of evidence as the facial features? No. So essentially they're interesting anachronisms, but they're not actually contributory towards the diagnosis. But still worth doing, because they can add to your own clinical judgment about whether or not you think that this is potentially a FASD or prenatal alcohol exposure. And as I said before, major defects, particularly midline defects, cardiac, renal, eyes, ears, and skeletal systems. There was a paper published by Lana Popova a couple of years ago that tabulated all the defects that have been noted with prenatal alcohol exposure, and realised they covered about, I think it was 18 out of the 22 chapters of ICD-10. So they're certainly frequent, but not many of them aren't contributory to the diagnosis. There are a number of other relatively rare syndromes whose features can overlap with fetal alcohol spectrum disorder. and they're named there, and I'm not going to go through each of them. So, what would we do if, for argument's sake, someone walks in the door and you make a spot diagnosis of ARC-SOG syndrome as soon as you see them, but we also know incontrovertibly that they have high confirmed levels of prenatal alcohol exposure. So I would hope that you would acknowledge that both those things are likely to be valid, and that would be included in your final formulation. Okay, so in terms of the physical examination, we should all start off with a morphological examination, looking specifically at the facial features, looking for congenital anomalies head to toe, and don't forget skin, i.e. neurocutaneous stigmata, a neurological examination. If there happens to have been an MRI or any cerebral imaging, certainly we're going to take advantage of that. But we wouldn't suggest, if that hadn't been done incidentally, that you order it routinely. So we're not suggesting that anybody who comes in with prenatal alcohol exposure should automatically have an MRI requested, because I think soon you'll get a nasty letter or email from the radiology department wanting to know why you've blown their budget. We should also look at a chromosomal array and other developmental blood tests, or if they can be done with a buccal swab as indicated. Okay, now we're going to do some work. So this is Olivia, and she has a palpable fissure length mean of 24 millimetres, which is a Z score of -2.1. So is that significant or not? Yep, so all those nodders around the room, you are correct, yes. Okay, so she has small eyes, and then this is her lip and philtrum. Okay, so why don't we just concentrate on the lip for this one. We'll go to the 3/4 view for the philtrum. So how would you rate her lip? Is it, let's start off with the easy ones. Is it a 1? No. Is it a 2? No. Okay, is it a 5? No. Is it a 4? No. So I think the answer is that it's probably a 3. Okay, and what about the philtrum? I said that we wouldn't do that till we got to the 3/4 view, but just on the frontal view, do you want to have a stab at the philtrum? Sorry? Yeah, 3 or 4 is what I'm hearing. Let's change to the 3/4 view and see if it changes your opinion. Okay, what do people think now? 3, yeah, okay. So is it a 3? Can we just double check? It could even be a 2 maybe. Perhaps, a 2 or a 3. So it's, and the purpose of that is just to illustrate the importance of doing the 3/4 view, because the frontal view you might be tempted to overcall it, but when you go to the 3/4 view you'll get a better estimate of it. Yep, I'll be with you in a sec. And if I can suggest, if you are taking photos, I usually take 6. So I take one front on with the flash and one without the flash. One 3/4 view with the flash, without the flash. One from the side with the flash and without the flash. Now when I come to use them, it's nearly always that the ones with flash are the best. So sometimes I'll just take 3 flash photos and be done with it. Yep. Sorry?
How do you get your 3/4 view? Do you have a way of getting them to the corner of the room, or how do you do it?
What I usually do is try and is get in that nice line to take the frontal photograph, and then I just tell the child to stay still and I move. Okay? Yep.
And what's your angle to the face?
Well,
45?
yeah, about 45, because you still want to be able to, I still want to be able to see their other eye. So if you can only see one eye, you've probably gone too far around to the corner. Yeah, does that make sense? Yeah, it's not particularly scientific, but Sarah?
And you had a sticker on the child's.
Yeah, so when you're taking a photo of the child's face, you need to have a sticker on their forehead, because as part of the software, it needs to reference a known length of material. So the sticker on the foot, you can buy stickers that are guaranteed to be 19.1 millimeters or something, but what we do is we just put measuring tape on the child's. We've just got sticky measuring tape in 1 millimeter increments, and we just put a little piece of measuring tape on the child's forehead and use that as the reference point. It doesn't have to be a particular length, because you can choose from a variety of different lengths in the software, whether it's 5, 10, 15, 20, right up to 50 millimeters if you want to. So looking at photos without a measuring tape is only really good for the lip and the philtrum, because you can't reference the eyes. Okay, so I think this is another one, and I think we've given you a clue there as to what the answer is. So that, as you can see, it's not exactly the same, but there's quite a bit of upper lip, and there's still that suggestion of the Cupid's bow shape to the upper lip. And then on the 3/4 view, again, you can see how much better it is on 3/4 than when it's washed out by the flash in the frontal view. And you can see that there's a nice valley and 2 perpendicular columns going right from the top of the lip to the base of the nose. And so that means it's a 2. So this person had a 3 on the lip and a 2 on the philtrum. Okay, so immediately you already know they don't have 3 facial features. The most they can have is 1, depending on their eyes. Okay, and again, just another example here of a philtrum that looks like it's a 2, a nice deep valley, and 2 perpendicular columns going from the top of the lip to the bottom of the nose, and just again illustrating the importance of getting the 3/4 view with a bit of shadow, ideally in the philtrum. And then a side view, and we can't really see any other abnormalities in the side view. And I guess in particular you're looking at the size and shape of the face and the nose and the ear, just to see whether there are any other little clues that you could pick up on.